Please welcome Dr. Casey Choi, who will now present his lecture on the biomechanics of midline correction.
Good morning. Thank you very much for your kind introduction, Dr. Maria. The theme of my presentation today is biomechanics of midline correction. I do not have any conflict of interest to disclose. Midline deviation represents one of the most challenging areas in the field of orthodontic treatment. Recently, treatment involving TADs or surgical interventions for severe cases have become more prevalent. However, it is important to note that not every patient requires surgery or TADs for their treatment. Some patients may not want to have surgery. I do use TADs and do many surgeries, but I will primarily focus on explaining biomechanical aspect of orthodontic means in this presentation. Let's take a look at a very simple case of asymmetry, where the midline is shifted towards the right side while the buccal segments remain symmetrical. In this scenario, a unilateral force was applied to correct the midline deviation and close the extraction space by chain elastic. As the elastic is pitted against the molar hook, there must be an equal and opposite reciprocal force acting in response to initial force applied. The midline has been successfully corrected, and the space was closed as planned. However, during the space closure on the contralateral side, there will be a shift in the midline back to right side, and initially symmetric buccal occlusion will become asymmetric as well. Simply speaking, Mother Nature does not permit this particular force system, and it is well described by Newton's first law. Therefore, reciprocal forces are always produced. They may not be desired. Thus, I could say that managing reciprocal force of the appliance is the most crucial aspect of correction of midline. Conventional methods of correction of midline involves crisscross elastics, bilateral or unilateral intermaxillary elastics, or unilateral activation of the spring. As we have previously discussed, unilateral activation of the spring is not considered effective. Traditionally, the most common approach involves treating the patient symmetrically and employing the intermaxillary mechanic in the finishing stage. Let's see what can happen when using crisscross elastics for midline correction. Once the teeth are aligned, anterior crisscross elastic was used. The equal and opposite force will correct the midline. However, the forces are located away from the center of resistance of both upper and lower segment. They produce clockwise rotation of both segments. In the occlusal perspective, if large friction between brackets and wire inhibits individual movement of each tooth along the arch wire, there is a rotation of whole dental arch so that a symmetrical horizontal overjet will be created by anterior crisscross elastics. Do all intermaxillary mechanics have side effects? The answer is yes. All intermaxillary mechanics do have side effects, but these side effects are not necessarily adverse. Let's take a look at a few clinical cases. Case number 1 presents a gross skeletal discrepancy with a local midline problem. The patient also shows asymmetries with canting of occlusal plane to begin with. This trimmed model visualizes the actual occlusal plane canting. The anterior crisscross elastic was used, and it corrected the midline, and the accompanied side effects corrected the cant of occlusal plane at the same time. Case number 2. presents with midline discrepancy and an uncoordinated upper and lower dental arch. Anterior crisscross elastic was used for midline correction. And both upper and lower arch rotated in desired direction as well to establish arch coordination. Case number 3 presents a midline discrepancy and a lower occlusal plane canting. The lower occlusal plane is downward on the left side after the leveling. A unilateral short class 2 elastic was applied. Note that the line of force in the upper arch passes close to the center of resistance of the upper arch, whereas the line of action of the lower force is significantly distant from the center of resistance of the lower arch. The lower midline moves to the right side and lower cant of occlusal plane was corrected. These cases demonstrate that traditional intermaxillary elastics are an effective tool for midline correction when accurately diagnosed in 3 dimensions, only when the associated side effects are adequately appreciated. One of the most important steps in midline correction is to establish a specific goal. Otherwise, the treatment can become highly inefficient, leading to delay in managing any adverse side effects that may arise during the treatment process. The goal could be upper dental midline, lower dental midline, or any other point depending on reasonable decision making. There are various midlines including upper and lower dental, facial, geometric, and apical base midline that can be a reference to determine a specific treatment goal. When the facial midline and dental midline align, it would be aesthetically pleasing and the patient will be happy with it. But there are some issues concerning the facial midline. First, we can discern that this gentleman's dental midline is significantly deviated from the facial midline. However, the general public may not notice. Second, some methods, such as using dental floss over the face, is suggested, but they lack reproducibility. It becomes easier to understand that lack of standardized method for establishing the midline in PA head plate when we consider this. The next reference point to consider is the apical base midline. This patient represents with severe dental midline discrepancy. The green arrows indicates the upper and lower apical bases. These are determined by the average point of the centers of resistance of each anterior teeth. The vertical projection to the occlusal plane reveals the deviation of the apical base to the upper and lower arches. This midline is closely related to the skeletal midline because when the teeth are spontaneously migrate, the location of the center resistance remains relatively stable. There are a close relationship between diagnosis and biomechanics, especially in the correction of midline. When a single force is applied at the crown, it causes rotation around a point very close to center of resistance. On the other hand, when a couple is applied to a tooth, the center of rotation is located at the center of resistance. A single force and a couple are fundamentally different physical quantities. However, their clinical manifestations can appear very similar to each other. Both of them leads to uncontrolled tipping. In this case, for example, the dental midline is off. However, the upper and lower apical base midlines are aligned with each other. If a couple is applied to each tooth, they will rotate around the center of resistance of each respective tooth. The midline can be corrected without need for any horizontal forces. Clinically, positioning the bracket slot perpendicular to the long axis of the tooth and using a flexible leveling arch wire will likely to produce these four systems. As the wire flattens, these four systems are produced. The presence of relatively small vertical forces at the terminal teeth are inevitable due to Newton's first law. These patients exhibit a symmetric face, however. There is a severe dental midline inadequacy in smile view. The frontal view of the study model reveals severe midline deviation and crowding as well. However, the buccal occlusion on both sides are symmetrical and exhibit class 1 relationship. In the PA head plate, the upper incisors are leaning towards the left side, while the lower incisors are leaning towards the right side. This patient represents a very large amount of dental midline discrepancy, but the apical base discrepancy is relatively very small. This implies that most of the dental midline deviation is dental, not skeletal origin. By covering the incisors to hide them, it is easily noticed that there is no significant skeletal asymmetry presented. This is a treatment objective of this patient. Note that facial and apical base midlines are located at the same position. Therefore, choosing these midlines as a treatment objective is a reasonable decision. The patient will be satisfied when the facial midline is chosen as a treatment midline, and also the orthodontist will be satisfied by the apical base midline as the treatment midline because it is biomechanically simple. Panoramic X-ray also shows a tilted state of upper and lower incisors to begin with. After the leveling, the remaining spaces were symmetrically closed. Note that there were no asymmetric extractions or use of asymmetric mechanics involving horizontal forces in this patient. End of the treatment. Sometimes we observe that the midline becomes deviated after the leveling. In this case, dental midline is on initially. However, the apical base midline is off. If a continuous leveling arch wire is placed, each tooth will rotate around its center of resistance, causing the upper midline to shift to the right side and the lower midline to shift to the left side. This is an iatrogenic midline discrepancy resulting from inadvertent leveling. This young lady does not show any midline issue to begin with. In her PA head plate, despite the alignment of upper and lower dental midlines, the lower apical base is shifted to the left side. In other words, the lower incisors are leaning towards the right side. The lower dental midline is shifted to the left side and became misaligned after initial leveling. In this case, the lower incisor segment is rotated clockwise so that the lower midline is shifted to the left side. This can be corrected either by using couple or a single force. But the single force is easier to rotate the whole incisor segment en masse. This patient presents a lower midline that has shifted to the left side due to the clockwise rotation of lower anterior segment. A cantilever spring extended from the auxiliary tube on the lower right molar was used to apply horizontal force. The single force applied at the level of the bracket produced the lower anterior segment to rotate en masse and corrected the midline as well. The geometric midline is the midpoint of the curve of established arch form, and it is measured from the center of resistance of the first molar on each side. Note that the center of resistance of the left molar is located distal to the central pit. That is because the lower left molar has tipped to the mesial side. Therefore, from an occlusal perspective, the location of the center of resistance lies distal to the central pit. Even though the molar keys are different and dental midline is off, there is no geometric midline discrepancy between upper and lower arch. When the geometric midline align with the treatment midline, it indicates that symmetrical treatment mechanics are applicable, making the treatment relatively easy. However, if the geometric midline deviates from the treatment midline, it suggests that the need for asymmetric extraction or asymmetric mechanics, which can complicate the treatment process. All midlines are transferred onto the occlusogram together. The next step is to determine the treatment midline goal. Selecting the facial midline as a treatment midline results in most aesthetically pleasing outcome. Both the patient and orthodontist are likely to be satisfied with this choice. The discrepancy between upper and lower apical base midline determines the potential need for surgery. Finally, the geometric midline discrepancy determines whether asymmetric mechanics are necessary. When none of these midlines align in one place, a certain level of compromise or decision-making becomes necessary based on where the value is placed. Let's compare these two cases. Both of them present asymmetric molar relationship and midline issues. Both cases present a class 1 molar relationship on the right side. However, in the upper case, there is a class 3 relationship, while in the lower case, there is a class 2 relationship. They are similar in that they both have an asymmetric molar relationship, but they are entirely different type of asymmetries, and the mechanics used are different from each other. The geometric midline determines the type of mechanic used. This case represents midline deviation, which needs an asymmetric mechanic because geometric midline is off. The dental midlines are deviated around 3 mm from upper and lower to begin with. The right side shows class 1 molar relationship, and the left side shows class 3 molar relationship. The panoramic X-ray shows symmetrical axial inclination of the molars. The line connecting the philtrum and the tip of the chin represents the facial midline. The apical base and geometric midlines are coincide with dental midlines. It was planned to retract her lip. The facial midline was selected as a treatment midline. Note that upper geometric and apical base midlines are shifted to the left side, while the geometric and apical base midlines are shifted to the right side in the lower arch. The geometric midline does not coincide with the treatment midline, and the amount of mesial movement of the molar differ from left and right side. Therefore, asymmetric mechanics is needed by asymmetric extraction of the upper and lower arch. After the space closure, before and after the treatment. Lip profile was improved by extraction as well. Let's take a look at a second case in which symmetric mechanics were used because geometric midline is on. This patient presents a midline issue in a different molar relationship. class 1 on the right side and class 2 on the left side. Note that the upper left buccal segments are tipped forward to the mesial side. These are the locations of the center resistance of the first molar. The occlusal projection of the center of resistance on the right side, perpendicular to the occlusal plane, is located at the central pit. However, on the left side, it is located distally. It is better visualized in occlusal view. Note that the center of resistance of upper left molar is located distally. This means that the geometric midline is shifted to the left side compared with the dental midline. In other words, if this geometry midline is selected as a treatment midline, asymmetry mechanics are not necessary, even though this patient has an asymmetric molar relationship. Once the upper left molar is uprighted, it becomes a symmetry case. Then how can we unilaterally move the molar distally without side effects? If a couple is applied to the upper left molar, the molar will rotate around the center of resistance and inclination of the molar becomes symmetric, resulting in a symmetric molar relationship. In the occlusal perspective, the upper left molar will move distally. The transpalatal arch was activated to produce a unilateral tip-back couple on the left molar and unilateral tip-forward couple on the right side. This is the deactivated shape of the transpalatal arch. It is twisted and bent in 3 dimensions. The bilateral tip-back spring was employed to counteract the forward tipping side effects. Therefore, class 1 molar relationship was maintained on the right side, while the left side, class 2, become class 1 relationship. Once we achieve a symmetric molar relationship, remaining treatment becomes symmetrical. In this case, upper dental midline and apical base is shifted to the right side. And it requires a single horizontal force at the center of resistance for translation of anterior teeth. However, applying a single force at the level of center of resistance would be very uncomfortable due to anatomic limitation. Therefore, the red single force is resolved into 2 components as depicted by yellow arrows, which is equivalent force system. The law of transmissibility tells us an intrusive force on the right side and an oblique horizontal force on the left side at the level of the bracket produce the translation anterior segment to the left side. However, amount of translation is very limited clinically. This patient requires a translation of the upper anterior segment. The single force is resolved into vertical and horizontal components. On the right side, a unilateral intrusion spring is placed, while on the left side, a cantilever spring produces horizontal force. After midline correction through translation, symmetric space closure was performed. Many factors influence the decision-making to establish specific treatment goal. Patients' satisfaction with aesthetic and function of their teeth is crucial, but sometimes biomechanically very difficult to achieve and perhaps time-consuming. At times, aesthetics might be compromised in favor of shorter treatment time and simpler procedures. A certain level of compromise is necessary, and biomechanical knowledge allows us to predict tooth movement, helping us to avoid unwanted iatrogenic side effects and guiding towards the most efficient treatment process. We have briefly discussed the correction of midlines without TADs or orthodontic surgery. we must carefully look at the nature of the midline problem. Biomechanics of midline correction is one of our greatest challenge. Thank you very much.